Yeah, it was quite a change. I retired here and took the same job in Nevada and worked there until I finally retired from there also. And this is a view out of my back window. And this is my house in June, and this is my house in January. It's quite different from Columbia. This is what I plan to do in the hours. This first hour, we're going to talk about introduction and the actinomycetes. Then we're just going to touch briefly on the yeasts and the dermatophytes. The third hour on filamentous fungi, then dimorphic fungi, and then what we call opportunistic fungi. And I'll explain these as we go along, just to give you an idea of what we're doing. I hope to stimulate you enough, and just give you enough of the basic science so that you can use this as a basis in evaluating your patient and knowing how to come to a conclusion, and enough clinical knowledge to raise your index of suspicion so that you'll think of mycotic disease in patients. I could tell you lots of stories where patients with mycotic infections went for years and years without a diagnosis. So I hope that's not going to happen anymore. We'll first go over just some basic ideas on mycology and medical mycology in general, just to give you some background. I will give you a bunch of material, but I'll emphasize things that I feel you should know. I think you'll be able to tell what I'm emphasizing, things that you should try to remember anyway. Now, do you know what this is? What that's called? It's called a fairy ring. And it's not a great illustration, but this is grass. Where do you push this? On the side? Oh, yeah, okay, here we go. This is grass, and this is a ring of mushrooms, and they're called fairy rings. I never knew that myself until I was told. But anyway, that's a fairy ring. Mycology is very interesting. That's how you make beer. The yeast ferment the malts and hops. That's what mycology is. It's the wine. Again, it's yeast that ferment the grapes and change it into wine. The bread, again, yeast, raise the bread. Cheese, all cheeses are made by the action of sometimes bacteria, but other times yeast. Gourmet mushrooms that you eat, that's mycology. Environmental toxins, and there are many of them, which we will not discuss. Biodegradation, they're used now even in oil spills to degrade the oil and manufacture chemicals. And then finally, disease. So we're only going to study this one little aspect. In fact, we're not even going to consider all the aspects of disease. Those are wine vats in California. They ferment them in these big stainless steel tanks and then put them to age in these barrels. It's not a good picture, but that's a steak covered with mushroom. So think of that. This is a tree with a bracket mushroom. You've probably seen those in the forest all the time. Rotted wood, that's the fungi, breaking down all the woods, restoring it to soil and nutrients. Bioremediation these are a variety of uses. Oil spills, cyanide, in mining operations, they use cyanide to extract gold and silver, and then they clean it up with fungi, dioxins, pesticides, produce organic acids, and many commercial products are made. Then also it causes lesions like this. The fungi are eukaryotic organisms. They have a true nucleus, unlike bacteria. They do not contain chlorophyll. At one time it was thought they did, but it's definitely shown they do not contain any chlorophyll. They have cell walls, and they produce mostly filamentous structures, and they produce spores. it depends on who's counting, but somewhere, anywhere, 100,000, 300,000. You know, in biology, you have some people who lump things together and other people who are splitters. So somewhere between 100, it's a lot of them. But there are about 300 that are pathogenic for man. There are only about 25 that are really important. On this chart, the only thing I want you to remember is fungi are eukaryotic and animals are eukaryotic. And this presents a problem for us in therapeutics. This is just to show you here. See, bacteria are way off here, and fungi are on this eukaryotic limb out here. Quite different from bacteria. And man is further up, primates further up. So that's our relationship. There are four, they're not families, what are they? Phyla, they're not even phyla. Anyway, four groups of fungi, and we're only going to consider these one group. Again, I don't expect you to remember it. I just want you to realize where we're dealing in the biological community. To give you an idea of size, I know you don't do labs anymore, but the cocci, if you looked at them, streptococci, pneumococci, they're all usually less than 1 micrometer. And protozoan can range from this, they can range to 2 or 3 feet. Well, not protozoa, but the nematodes can range to 3 or 4 feet. And fungi are in the 10 to 15 micron. You can see them with a regular light microscope. They're not like viruses that you need an electron microscope. You can see them quite readily, and they're quite large when compared to bacteria. Now, we're also going to talk this morning about actinomyces. This is a group that were thought to be fungi, but they're really now known to be bacteria. The reason they're usually still left for the mycologists to discuss is, and why they were thought to be fungi, is, well, it's the tradition that they were thought to be fungi. The clinical infections they cause resemble the mycoses. They grow on most mycotic media. In the lab, if accidentally you didn't say you wanted a fungus culture and it went to bacteria culture, it would still grow. The actinomyces will usually grow. And they grow slowly. In almost all bacterial cultures, if you get the specimen to the lab today, sometime today, they'll streak it on media, incubate it, and they'll look at it the next morning. So 12 to 24 hours, you get some good growth. Fungi are much longer to grow, and we'll talk about that as we go through specific fungi. But the actinomyces grow very slowly also, 24 to 48 hours, not as slow as some of the fungi. The colonies, the gross colony in the lab will resemble a fungus culture. And even microscopically, they look like strands of mycelium, which are typical of fungi. And we're going to talk about those a little bit in the last half of this hour. Now, what is medical mycology? There are 4 types of medical mycological problems. The first is hypersensitivity. This is true allergy. If you go into pediatrics, you could be telling your mamas when they have an allergic child, don't use carpets in the room, use tile or linoleum floors so you can mop them up and keep them clean. The problem is molds and the spores of molds that are growing in there, and we'll tell you a little more about spores as we go along. So that's an allergic reaction. The next type of reaction is mycotoxicosis. This is a toxin produced by the fungus as it grows on a substrate. Usually the substrate is grain. In warmer climates, there are always problems with the fungi growing, and the people eat the grain and they all get sick or maybe even die. In South Carolina, we used to have in the 70s big problem because the molds would grow on the corn, the cows would eat the corn, they produce aflatoxin, and the aflatoxin would come through in the milk. But that's all been cleaned up years ago by knowing better methods to store the grain so the fungi don't grow. And the milk is tested in the state lab and in the Department of Ag lab, both, for any toxins that could be there. Mycetismus is a preformed toxin. You've heard of mushroom poisoning, I'm sure. That toxin is in the mushroom itself. It's not where on the mycotoxicosis, it's produced by the fungus growing on the grain. This is in the mushroom itself. So you eat mushroom, you get mushroom poisoning. Incidentally, ask a question anytime. Just interrupt me when you have a question if you want me to repeat anything or whatever. So that's a preformed toxin. Requires different methods for treatment if you see them in the emergency room. We're not going to talk anymore about any of these. We're just going to talk about infection. There are a bunch of hypersensitivities, like the very first part. If you run into any of these along in your readings, farmer's lung, malt workers' disease from people who work in malt places, beer, cheese washers' lung. They sound funny, but these are all actual names of diseases in certain parts of the country where these commercial activities occur. Now we're going to discuss just, we'll be in this, these species for the first 4 hours, and then we discuss the other 300 in the last hour. Now, why do they cause disease? Well, it's not, some of them produce toxins in the body, but that's not really a big item. Most of the time, they become infectious because they increase their metabolic state, and you'll get this as we go along a little more, modify the metabolic pathways and modify the cell structures. And we'll get into this a little more when we discuss some specific diseases. They tolerate the high temperature of the human body. They survive in tissue. A tissue environment is hostile to microorganisms and foreign bodies and everything, but certain of these fungi will survive in the body and they withstand the host defenses. Mycology was only relegated to the bottom of the pile for many, many years, and it's becoming much more knowledgeable, physicians are, and we're seeing a lot of infectious disease specialists specializing in treating mycology diseases. And the reason is we have an increased frequency. We're seeing a lot more. Physicians are much more aware of it than they were before. The laboratory personnel are much more aware and better trained to diagnose them. And more invasive procedures are used on patients. And when you do an invasive procedure, you can instill organisms from the environment. So we're seeing more infections that way. And immunosuppressive drugs suppress the patient's immune system, and you get more infection. In fact, this is a whole specialty of some infectious disease people, treating immunosuppressed people, whether they're being treated for cancer or AIDS or whatever. And it's a specialty in itself. I'll be telling you like one drug to treat something. Well, they go into very different differentials on how much therapy and what doses and which drugs. We'll discuss a little bit of that in the last hour. And the increased immunosuppressive diseases and better laboratory diagnostic tools. The mycologists are way behind the bacteriologists in developing molecular methods for identification, but we're getting there with some of them. So we'll discuss this, and this is the rest of it that we won't discuss today or this week. Morphology. This is an important part because we still have to do the diagnostic methods by looking at the organism we isolate or that we look in tissue. And the fungi come in two main forms, the yeast or the mycelial form. And then we have a group, and these are the most important, called dimorphic fungi. They'll have two forms, a yeast form and a mycelium form. The yeast form, they go into this when they're in the tissue. When they're in nature, they're in a mycelial form, and they go through a cycle which we'll discuss a little bit more. There are two types of hyphae, and these words are used interchangeably a lot, hyphae, filamentous, or mycelium. Those that are septate and those are cenocytic. This is extremely important in identification, and I'll mention these with specific diseases later on when they are an important identifying characteristic. Here's a yeast, a single cell that reproduces by budding. This is a mycelium. They grow from the apical points, as you see this way, progressing. This is a cenocytic hyphae, no septate, no septums, septum, septa. And here's the septum and septate hyphae. Very important, and specific instances will all emphasize at the point where you need that. The yeast form is also called the parasitic form or the tissue form. And in the lab, if we culture at 37 degrees, we grow the tissue form. In all mycology labs, we grow them at two temperatures. 37, what's 37? C, body temperature. And then at 25 degrees, which we call room temperature. It's a cool room. There are two kinds of spores. They're sexual and asexual. And I'll only emphasize these when they're important with certain diseases. Fungi confuse, just like man and women, and they form a zygote. And it's a sexual process. But the majority are asexual. And the purpose of this is just to show you the variations. And this is a diagram of the various spores. And I'm going to emphasize some of these at the point where they're critical. And Jesus was a mycologist, the first mycologist, when he said, "By their fruit you shall know them," because we identify fungi by these fruiting bodies, the spores. And just like identifying spores, okay, you didn't laugh, huh? Epidemiology. Almost all fungi are saprophytic. Not everyone, but they all live in nature in the soil. If I were to wipe my finger on this table and put it on a petri plate, we'd grow a whole bunch of fungi. You probably see them in your refrigerator. And moldy fruit or moldy cheese or moldy bread, those are fungi. Just to give you an idea that the ecological isolation of many, these are the most important ones we'll discuss, but are in fairly recent years. Maybe not to you, it's not recent, but to me that's still recent, all within my lifetime. In general, there are only about couple of real exceptions that they're not contagious. In fact, when some sort of human-to-human transmission occurs, it's worth a paper on it because it's very unusual. But in general, mycotic diseases are not contagious. The main reason we get infected are the inoculum size and the resistance of the host. The majority of normal hosts do not get infected with fungi. They're usually, or it's a mild infection, but those who are impaired will get a good infection. And I'm going to tell you, if I remember, when we talk about histoplasmosis, I'll tell you about an outbreak in Lawrence County where we saw this whole range of serious infections or variety infections. Okay, that's essentially what I said. It depends more on the host than on the organism. Now, here's something you've got to try to remember. There are three status of disease, or not disease, of isolation of organisms, because you'll get a report from the lab that says we got XYZ, we isolated. Now, what you're going to have to do is this colonization, and I've got a diagram that'll show this, or fungemia, which just means the organism is passing through temporarily in the body. Sometimes a tooth is pulled and it sets organisms, endogenous organisms loose, and you get them in the bloodstream, or a real infection that requires your attention. This is a nice diagram a friend of mine gave me. This is a body, an animal body, the mouth, the intestinal tract, the anus, respiratory tract on the side, urogenital, eyeball, and skin. No problem here. Colonization, these organisms, you can get it out of the throat, but it's just colonization, meaning the organism is just living there, not doing anything, or in the respiratory tract, or in the rectum, or urogenital. See, this is on the surface of the skin. The skin is a zoo. There's all kinds of bacteria and fungi and yeast on the surface of the skin. And you got to know, okay, this is just colonization. It's not meaningful. Or did it set up an infection in the lung? Here it's penetrated into the skin. Here it's setting up an infection. So those are things you're going to have to keep in mind. Okay. A lot of the fungi we will discuss occur in certain geographical areas. And the reasons are not clear, and sometimes it has to do with soil types. It's believed, not really proven, and most of it is not known why they occur. But if I'm going to tell you this disease occurs in South America, it doesn't mean you don't have to learn about it, because you're going to see a patient who worked in South America and came here, and so you've got to be aware of some of these diseases, especially with the way air travel is today. You know, the biggest problems now with the influenza pandemic that's being expected is that before you can make a diagnosis, people are going to go all over the world, and before they show the symptoms, so the disease is going to be spread tremendously. It really is going to be a big problem when that happens. But it occurs with the mycoses also. We also use the term endemic mycoses, meaning they occur in a certain area. Again, I'll tell you these as we discuss certain major diseases, where that's important to know. You've got to take a patient history. It's most important. You've got to have a medical history to know their immune status and whether they're susceptible. Travel, because we just talked, the endemic mycoses occur in different areas. Did you travel to Arizona? And you're going to have to know some of these, and I'll emphasize those as we go along. Occupation, certain occupations. You remember Silo-Filler's disease and Brewer's disease and all these others that depend on an occupation. Just like in bacteria, you've got to know for the anthrax, if they work in a wool factory. We've had problems in Anderson in particular. They used to have a lot of wool factories. I don't know if they still do. And we'd see anthrax cases from there. Well, the mycotic diseases, you have these to worry about also. Their avocation, because some of them will be, whether they're hunters or out in the woods. In fact, we've had some cases right here from this hospital, when it was just a VA hospital before the medical school, where it's the avocation put the people at risk for certain of the mycotic diseases, which I'll tell you about later. See, Dr. Zook took a history. Okay, how do we diagnose mycotic diseases? We have a variety. I'll go through each one of these. A wet mount is when we take a little sample. It could be pus from a lesion, the scraping of a skin, athlete's foot, or various lesions. We put a drop of KOH on the slide, and you mix the little piece of tissue or pus in that, and you heat it gently, and then you examine it. The reason you put it in KOH, it dissolves a lot of the cellular material, so you could see the organisms themselves, rather than being hidden by either the pus or the tissue reaction or other tissue cells. Here's a lesion. This was a 70-year-old farmer who came into this hospital. He was up at Spartanburg. This lesion on his leg had been treated by a local doc for 3 or 4 or 5 weeks, and then he referred him to the VA hospital here, where a KOH mount was made, and there were these distinctive yeasts, which I'll tell you about more when this is blastomycosis. So antibiotics don't touch the fungi because they're just different. And so the patient wasn't doing well at all until he got here, made a diagnosis, and he got put on our typical poison of that time and was cured. A skin test is a form of hypersensitivity. That's what it looks like. It doesn't show real well. That's skin test from a kid for histoplasmosis. We don't use it for the usual diagnosis when a patient comes in anymore because it interferes with the serological tests and gives a false positive test sometimes, not always. But we do it for epidemiologic studies where we're looking for an outbreak of disease to see who has contracted it. Serology are blood tests. Fungi are poor antigens, and we have a lot of cross reactions. And I'm just going to tell you about some of the tests as we go along that are pertinent. They're not all pertinent to each disease. There's no general test for, does this patient have a fungus infection? You can't send for a blood test. Is this a fungus? You have to specify what fungus infection you're looking for. IgM, IgG, IgG. You've had immunodiffusion, have you, somewhere along in the line? It's also called Octoloni technique, where you can either have, this is usually the known antigen, and then you have duplicates of your unknown serum. So let's say this was you're suspecting histoplasmosis. You have a histoantigen here. These are other sera from other patients. This patient, you see these bands here, that means that's a positive reaction to histoplasmosis. Immunodiffusion test. Most of them measure antibody. It would be better if we could develop an antigen test because everybody doesn't produce an antibody. And these are very slow in coming. We've got one, cryptococcosis, histoplasmosis, and we're not real sure on this because the physician who developed that never published his results. He keeps it proprietary, and he runs a private lab to detect antigen with his specific test. Aspergillosis is just starting to come along. It's been around, I guess 5 or 6 years, but there's not enough experience to say how good it is, but it's a help. The Cryptococcus antigen's been around for about 25, 30 years, and it's a key to your diagnosis, and we'll talk about that when we talk about cryptococcosis. Fluorescent antibodies are a neat trick, not used too much anymore, but you can take a histologic section. That's the trouble. Surgeons always put everything in formalin, so you can't isolate anything from it. But with the fluorescent antibody, you can make a tissue stain, and you can do the fluorescent antibody. Fluorescent antibody ties a fluorescein dye with an antibody to whatever disease you're trying to study. And with a special light shining from the back of the microscope and a specific eyepiece in the microscope that blocks out other extraneous radiation, then you could see the organism. And you have two identifications that way because you can see the morphology of the organism and you can also see the antibody-antigen reaction. And what's neat about it is it does viable organisms. If nothing grows out or just a speck grows out on the culture, you can take that speck and do a fluorescent antibody. And it identifies non-viable organisms. They could be dead, or in the case of tissue, formalinized, and you can identify them. Here's a yeast identified by fluorescent antibodies. See how nice it fluoresces? You see the morphology of the yeast with a single bud and a narrow base here. And you can see that the antibody is reacting with it. Biopsy and histopathology. What was not known too much before is that, the immunodeficient host just produces necrosis, where the fungal infections in a normal host, you'll either get a granulomatous or a pyogenic reaction. You know what pyogenic is, don't you? Pus cells and white blood cells, usually the polys. Here, this is actinomycete, and these are all polys. I guess you can't tell that too much from where you're sitting. And this is a granulomatous giant cell, the Langerhans giant cell in a reaction. In most of the fungus infections, when the infection is early stages, you get a pyogenic reaction, and then later on a granulomatous reaction. Then we have a special stain called a GMS, gamma-rene methenamine silver stain, which will stain the organisms black against the green background. This is neat. You can see it's an organism. The bad part is you can't tell anything about the kind of reaction you're getting, but at least you can see those. And a lot of times the organisms are going to be dispersed in the tissue. There aren't going to be many, and you might miss them looking through a usual microscopic slide. But with the GMS stain, they stand out very strongly. Culture, of course, is the gold standard. We usually use what's called Sabarod's dextrose agar, SDA, and this agar is made a little on the acid side because the slight acidity inhibits most bacteria. Most bacteria have to grow in close to a neutral medium. Then we also put antibiotics in some, and some with cyclohexamide. Cyclohexamide is an antimycotic agent that hinders the growth of certain fungi, a few pathogenic fungi. That's why we'll usually use more than one medium, so that we'll get it on this plain agar. And then antibiotics to inhibit bacterial growth. Bacteria, as I said earlier, will usually grow out 18, 24 hours. But our fungi can take weeks, sometimes 2, 3, 4 weeks to grow. So if you didn't have something in there to prevent growth, bacteria would overgrow your plate and you'd never see your fungus. We always incubate at 2 temperatures because we'll be talking about the dimorphic. If you remember, dimorphic fungi have 2 forms, a yeast form. And sometimes you'll isolate them, organisms, at one temperature, but not the other. So we always isolate at 2 temperatures. And finally, we're coming into the modern age with a few DNA probes. They are rapid. When you've got to have the isolate first. And you can look at it in an hour or 2 and get an answer. And it's only for 3 or 4 fungi. They're very specific, though. They're species specific, and they're also expensive. Now, treatment. I mentioned in the very beginning about the eukaryotic cells, and that's a problem because if something's going to affect the eukaryotic fungus, it's going to affect the eukaryotic host. And so it's hard to find something that will destroy the fungus without harming the patient. We have a lot of side reactions. A cause of irreversible cell injury is cell membrane damage, and that's usually what almost all the antibiotics do. They induce cell injury and the cell membrane becomes permeable, and the innards of the fungus exude, and then the organism dies. All cells contain sterols, but the difference is mammalian cells have cholesterol and fungal cells have ergosterol. And I don't expect you to remember any of this. I just want you to know that somewhere along in the development, we have different antibiotics, and they will react in different areas in this metabolic process. The polyenes are our oldest antibiotics. The amphotericin B was developed in the early 1950s. The azoles started coming around later, keto in about 70, 80, the 90s, and now these last two azoles in the last, well, they've only been available the last 4 or 5 years. They've been around being studied for about 10 years. Amphotericin B binds to the sterols, but it has a greater affinity for the ergosterol in the fungus cell wall than it does for the human, but you still get a lot of toxicity in humans. These are the side effects of amphotericin B. It's also known as amphoterrible. Since those last couple of azoles I've shown you, we're getting away from amphotericin a lot more. But the patient had to be hospitalized for this, maybe even 2 or 3 months, and they have to be medicated ahead of time to prevent the fever and chills and these other side effects. There are a few rare serious side effects from itraconazole and fluconazole, and so far the other two, voriconazole and posaconazole, side effects are very few. But again, they haven't been around long enough. The others are griseofulvin. Griseofulvin, I'll talk to you a little more in the dermatophytes, those that invade skin and nails. What they do is they get incorporated in the tissue itself, and then the fungi can't penetrate it. So if you have a fingernail, it's going to take 2 or 3 months for that fingernail to grow out. So the fungus, only the new nail will not have fungus. So you've got to wait for the whole thing to grow out. In toenails, it may take 6 months to a year for the toenail to grow out, and the new growth having the griseofulvin in it, preventing the organism from penetrating. And these others we'll discuss a little bit as we go along with specific diseases. These are a new classification, echinocandins. You've heard of terbinafine. If you haven't heard terbinafine, you've heard Lamisil, because there's, we'll skip that for a moment. I think I told you all that. Penetrates through the layers. 5-fluorescein interferes with RNA synthesis. Again, I'm not going to ask you anything about mechanisms of action. Okay. I thought I had another slide in here on Lamisil. I had a picture of, you see it now quite a bit. They got Digger, the dermatophyte, and that's Lamisil that they're advertising now. It's only been around 3 or 4 years. Let's move on. We'll talk about them generally in classification, clinical classification, cutaneous, subcutaneous, systemic, and opportunistic, and we'll go into that a little more. Oh, wrong way. With specific diseases. The cutaneous rarely invade deeper tissue. We also call these usually, they're called dermatophytes. They're usually superficial. Subcutaneous, again, are just confined to subcutaneous tissue. We'll discuss that a little more with specific diseases. And the systemic, these are the most important. These are almost all the dimorphic fungi. They are all the endemic fungi. So you got to be prepared to identify these. Are we going into